Hi, my name is Michael Ritchie, and I'm going to be talking about septic shock and the history of septic shock, and then how to use that to fine-tune the art of resuscitation. So we're going to go over the history of septic shock resuscitation. We're going to go over the Sepsis 3, or the 2018 Surviving Sepsis Campaign Bundle, the pathophysiology of sepsis, the future of resuscitation, and then how that works with the 2021 Surviving Sepsis Guidelines. So when we look at the history of sepsis, we can go all the way back to the 4th century and Hippocrates, when he recognized fever as a symptom of infection. And then we looked at whenever they described inflammation as rubor, dolor, color, and tumor. In the 16th century, that's when Ambrose Pare was able to find the surgical source control for wound infections was helpful in infection. And then when we looked at the invention of the first antiseptic, and then Louis Pasteur was able to isolate bacteria from a bacteremic patient. And then the main thing that I want to talk about from it was that we didn't actually define sepsis until 1989, which is not that long ago that we ended up with the definition of sepsis. And then 2001 was when everything changed, and this was Emmanuel Rivers whenever we talked about early goal-directed therapy, and he created this algorithm. And this algorithm, what it did is they said, all right, if somebody comes in with septic shock or suspected septic shock, that they would get supplemental oxygen, and then they would get intubated if necessary, and then they got a central line placed, and then whenever they had the central line placed, they would get continuous arterial monitoring, and then they would get sedated or paralyzed if necessary. And then if their CVP was less than 8, then they would get crystalloid or colloid until they had a CVP of 8 to 12. Once they were able to get a CVP of 8 to 12, if they had a MAP that was under 65, they got started on vasoactive agents or vasopressors. They then got a central venous gas from the central line. If their central venous gas was less than 70%, they got transfused to a hematocrit of greater than 30%. If it still was less than 70% after a hematocrit was over 30%, then they were started on inotropic agents. And then if all of their goals were achieved, then they were admitted into the hospital. So his expectations were that all of this would get done while they were actually in the emergency department, which is a whole lot of things to be able to get done. But what he found out was he had really, really good results from it. What he said was he took someone that had, in standard therapy, had almost a mortality that was like 49% mortality and took it down to like a 33% mortality. And if you looked at it over 60 days, you had something around like a 57% mortality that went down to a 44% mortality. So a huge improvement in mortality whenever they did these things. Now, there's arguments to be said with it on there that says, hey, why was there such a huge mortality for the standard group whenever that's not the normal mortality rate for people in septic shock kind of nationwide? But he did show a significant improvement. And so that helped start the Surviving Sepsis campaign. The Surviving Sepsis campaign was all about doing early goal-directed therapy. And so the 2004 guidelines were what kind of brought that around and said, hey, these are the things that we need to be doing. And then 2008 and 2012 were kind of reiterations of that, or what we could do to get those things better. And then there were some big changes in 2014 and 2015. And those big changes were the PROCESS trial in the United States, the PROMISE trial in Europe, and then the ARISE trial in Australia and New Zealand. And what they said was, we don't think that early goal-directed therapy is actually where we need to go. And I think that was one of the issues that they talked about with Manny Rivers, is he did so many things. He implemented like 15 things and showed a mortality benefit. But then the question is, did you actually need all 15 of those things? Or was it helpful to just do 3 of them or 5 of them? Or were there a lot of things that maybe weren't helpful? And then we realized that you didn't need to have a CVP of 8 to 12 in septic shock resuscitation. You realized that dobutamine probably wasn't a good choice whenever you had somebody that was in septic shock. And so they said, well, what else isn't something that we need? And they started going into it more and more. And so in this, they said, what we're going to do is we're going to do the early goal-directed therapy, and then we're going to do whatever we want. And what they found out in all three of these was that there was no difference between doing whatever they thought was their standard of care versus doing the early goal-directed therapy that we saw back in 2001 with Manny Rivers. And so some people said, hey, maybe this means that Manny Rivers was not good, or we shouldn't be listening to him. And I don't think that that's true. I think what we're seeing is that he was the one that showed that early goal-directed therapy was that you needed to get on these people early. Like, you needed to jump on them and say, this person's sick. We need to do all these things early in the emergency department, jump on them. And that's how we make a difference. And then after all this, we actually came out with a new definition of sepsis. So people started really complaining about how we define sepsis because it became very open to interpretation. And some people use sepsis for one thing when they meant another thing. Whenever people would say, oh, this person has sepsis, and it was a 19-year-old with a sore throat and a fever, and they would qualify as sepsis. And then you would also have somebody that had multilobar pneumonia with kidney failure, and they would also qualify as somebody who'd be like, man, that person's septic, whenever they meant that they had severe sepsis in those current definitions. So they really looked at kind of redoing the definitions for how they did things. So if we look at the original definitions, SIRS plus infection equals sepsis. And then you take sepsis and you add organ dysfunction to it, and then sepsis plus organ dysfunction will end up with severe sepsis. And then you take severe sepsis, and then if they still are hypotensive after resuscitation, then that would qualify them more of saying that they're in septic shock. Well, one of the concerns was that just SIRS in general, which is your systemic inflammatory response syndrome, is a pretty common response to being infected. Like I mentioned before, if you're 19 years old and you have a sore throat and you have a fever and you have a white count and you're a little bit tachypnic from that fever, then what's going to happen is that you're going to end up saying that person has sepsis when that's just a normal response to infection. As opposed to somebody having severe sepsis is actually having an abnormal response to infection. And so that's where they wanted to change the definition. And they said, we want sepsis to be an abnormal response to infection, as opposed to sepsis being just a normal response to infection. And so they kind of shifted it between the sepsis 2 and sepsis 3. And so what they tried to do is say, if you have SIRS, this is a normal response. This is not considered sepsis. If you have an abnormal response where you start getting organ dysfunction, that's whenever you're going to be defined as sepsis. So severe sepsis became sepsis, and then you ended up with septic shock. Just getting rid of severe sepsis as a diagnosis. Now, septic shock, all they did with septic shock is they gave it a more formal definition. They said, we think that it has to be hypotension after resuscitation with a lactic requiring vasopressors. And so with having those specific criteria, it kind of made it easier for you to be able to certainly diagnose somebody as having septic shock. Also, what they tried to do is they tried to look at different scoring systems that would kind of help somebody identify somebody as being septic, and they talked about sepsis 3 and the SOFA score. So sepsis is where they went ahead and looked at saying, what can we do to say this person is more septic than this person, or this person's sicker or less sick? So SOFA score in the ICU became a really big score, and that's the sequential organ failure assessment. And it's a 0 through 4 within 6 different systems on there to be able to look at it with it. And then obviously the sicker somebody is, then the more that those numbers are. So you can go all the way up to a score of 24. And so that the higher their score, the sicker the person is, the higher the mortality risk with it. Now, keep in mind, if you look at this, is it does require a lot of labs. So you need to know what their bilirubin is, their creatinine, you need to know what their platelets are. So it's a lot of things that potentially need a bit of investigation to be able to do it. So it's not easily done outside the ICU, where you're going to be seeing a lot of patients where you're not going to be waiting on all these labs or doing all these labs on every single patient that comes in with a fever. And so that's where we came into QSOFA. And QSOFA was, what can we do to try to get a score outside of the ICU? And so whenever they did this, they said, of the organ systems, what are the ones that actually can be done with clinical exam? And so the clinical exam ones showed hypotension. And so they looked at a systolic less than 100, respiratory rate greater than 22, or a change in mental status. So a GCS of less than 15. And if their baseline GCS was left at less than 15, then it was a drop in their baseline GCS. And if you had a score of greater than or equal to 2, then that was a suggestion that you had a high risk of poor outcome. Now, the issue that you would expect from here was that it was identifying a lot of really sick people, but it wasn't identifying the people that were like early on, not quite there yet, but were heading in that direction. So they realized that of the people that qualified for QSOFA, those people were very sick and needed to get dealt with, but they definitely missed a lot of people, which was what the opposite was true for SIRS, where they were identifying people that were not that sick, that were like young and just having a normal inflammatory response, that this was missing some of the people that were eventually going to kind of progress to getting sicker and sicker through there. So that's what we came out with the 2016 Surviving Sepsis Guidelines after all of these changes happened and everything we looked at, and there were a lot of big changes that happened with it. And so this was a huge change in everything that had happened before it. And so if we look at what they based it on in 2016, whenever they originally did the initial resuscitation, they said sepsis and septic shock are medical emergencies, and we recommend treatment and resuscitation begin immediately. And that was just what we call BPS, or best practice statement. So no data behind that. That's just what they recommend. They also recommend a 30 ml per kg IV crystalloid fluid bolus within the first 3 hours. Again, that was a strong recommendation, but low quality of evidence. We recommend that after initial fluid resuscitation, you need frequent reassessment of hemodynamic status, best practice statement. We recommend further assessment to determine the type of shock with clinical examination, again, best practice statement. And then we suggest dynamic over static variable. So and looking at changes that are acutely happening to decide if someone's fluid responsive or what kind of shock they had. And this was a weak recommendation, low quality of evidence. And then we recommend an initial target map of 65 or above in septic shock requiring vasopressors. And this was actually a strong recommendation, moderate quality of evidence. And then the last thing was they recommended normalizing lactic in patients with elevated lactic levels as a marker of tissue hypoperfusion. And this was a weak recommendation, low quality of evidence. So I think this is really interesting. You look at this initial resuscitation and the first 7 things that they mention, 3 of them just say best practice statement, no data behind it whatsoever. And all the rest of them, there's only 1 that even has a moderate quality of evidence. All the other ones have weak quality of evidence. So this was one of the things that came out that was a concern, was that everything changed. We had to do 30 mLs per kg. We had to do all these things when there's really not that great of data behind it as we were doing it. When it came to antimicrobial therapy, the data was definitely better. They wanted to give IV antibiotics as quickly as possible, ideally within the first hour, and that was a strong recommendation, moderate quality of evidence. And then they recommended broad spectrum antibiotics, or what's going to likely cover the suspected pathogen, and that was a strong recommendation, moderate quality of evidence. And then source control being a big thing, as they recommend trying to figure out where the source was, being able to remove the source from a source control issue as best practice statement, and then remove any intravascular access devices or anything that would be suspicious for the cause of sepsis, and that was best practice statement as well. So if you look at the data on it, it's not a whole lot of strong data for it, but this is what we recommended. And what we learned from the 2016 guidelines was early fluids, early antibiotics, and source control. Those were the big 3 things that came out of it. And specifically early appropriate antibiotics. So if somebody had MRSA and you're giving them penicillin, you're giving them antibiotics, but it's not appropriate antibiotics. So it's early appropriate antibiotics, what you think would be taking care of the disease that you think is going on. So this was a paper that came out that showed if you delay antibiotics, for every hour that you delay antibiotics, the mortality goes up, which makes sense because if that's what's going to be able to help kind of reverse the sepsis or septic shock that that person's going into. And then source control. So I think source control is very important. If they have an abscess, drain the abscess. If they have an obstructed kidney stone, either put in a stent or put in a nephrostomy. If they have cholecystitis, then they may need a drain. If they have an empyema or they have an indwelling catheter, then that's something that needs to be dealt with as well. So if you should be looking for a source because they're not going to get better until you do source control. Here's some examples under ultrasound. Or you have an abscess, you have cholecystitis, you have a kidney stone with obstruction behind it. All of these things need to get dealt with in order to appropriately treat this person that's in that's septic or has septic shock. So again, early fluids, early appropriate antibiotic source control, and then they added a 3-hour bundle and a 6-hour bundle. And this was really big. They said in the first 3 hours, you needed to make sure you measured the lactic, drew blood cultures, administer antibiotics, and administer your 30 mLs per kg. And then at 6 hours, you needed to reassess, right? If they're still hypotensive, you needed to make sure that they were going ahead and put on vasopressors, that they have a central line in, that they are remeasuring the lactic. Those were the recommendations that were given. They then did an update, a brief update in 2018. And that 2018 update actually increased it to a golden hour. And that golden hour looked at early fluids, early antibiotic source control, same thing as 2016, but they wanted all of this stuff done in the first hour. So they thought that in the first hour, you should have a lactic done, cultures done, antibiotics done, fluids started to at least begin the 30 mLs per kg, and then give vasopressors if they're still hypotensive after that first hour. So it really kind of escalated that timeline to say when we should be doing these things. And then here is what the Surviving Sepsis campaign came out with on all the things that you should be doing in hour 1 bundle. And that was from the 2018 updated guidelines. So now that we understand the older guidelines, I want to kind of look at the pathophysiology of septic shock. I want to look into why people get sick whenever they get septic, and then show how that's molded our newest guidelines, which were the 2021 guidelines. So in people that get septic shock, this is an abnormal response to infection. You get this dysregulation of the immune response. You get this huge release of cytokines. And I think one thing that we've learned and appreciated a lot more since COVID was just cytokines, and seeing all that inflammation and all those inflammatory markers that we started looking at during that time period. And this is what we're seeing just in septic shock and what has been going on when all this happens. But you end up with endothelial dysfunction, you end up with dysregulation of the coagulation system, cardiovascular dysfunction, microcirculatory failure, you get cytopathic hypoxia, endocrine dysregulation. All of these things are happening because you get this huge release of cytokines. And with these release of cytokines is that often the body responds with anti-inflammatory cytokines, and they're supposed to balance each other out. And then that's how people are able to survive. But if you don't have the appropriate response, if you end up having significantly more inflammatory response, then you can get an anti-inflammatory response. Then you start going into multi-organ dysfunction and failure, and then end up in shock. So it's a matter of having an inappropriate cytokine release. And if we look at our cytokines, we have these pro-inflammatory cytokines that get released first, and then the hope is that you end up having these anti-inflammatory cytokines that come through, and they're able to kind of do what they need to do afterwards on there. So whenever we're doing these things, we're always looking at inflammation and saying how inflammatory are they, and what are the consequences of this inflammation. So the main thing to take away from cytokines is that they do two things in terms of vascular dysfunction and fluid, is they cause vasodilatation and they cause capillary leak. So if you look at vasodilatation, sepsis causes an increase in the activity of inducible nitric oxide synthase, and that helps create more nitric oxide. And nitric oxide is a potent vasodilator, and so it dilates all those vasculature, and it makes it so that you're more hypotensive because everything's dilated. Additionally, those cytokines will actually break down the bridges between cells, and so it'll make those gaps between cells very leaky, and you'll end up with like a capillary leak, and everything will start third spacing out into the interstitium. And so an analogy for this would be if your normal intravascular volume is about 4 liters. And so if you have a 4-liter bucket and it is full of water, and then you dilate it out to a 6-liter bucket and you poke a bunch of holes in it, then yes, you are going to be hypotensive because you have very little fluid in that bucket. And so this is what you're dealing with when somebody comes in septic shock, is that you don't have enough fluid in that bucket because there's holes in it, but also because it's now a 6-liter bucket and not a 4-liter bucket. And that's why people respond well to getting those fluids, because you're trying to fill that bucket back up. And so this is where those guidelines come from. Early fluids, try to fill that bucket back up so they're no longer hypotensive. And so this is where we kind of got what we were doing in terms of our guidelines. Now, I do want to bring up a couple of concepts whenever it comes to fluid resuscitation. So as we can see here from preload, preload is the volume in your ventricle at the end of diastole that creates that stretch on the ventricle to allow it to squeeze, is that you need to have that venous return. You need to have that blood flowing back to the ventricles so it can cause that stretch of the ventricles and allow that squeeze. So new concepts to think about are venous reservoir and mean systemic filling pressure. And so these are things that are going to kind of help understand why giving a whole bunch of fluid isn't necessarily helpful. So everybody has stressed and unstressed volume. So we have a certain amount of volume in our venous system, and a lot of it is what we call unstressed that we don't really use. Think about it as having a dam, and you have water flowing over that dam, as you have a lot of water underneath that water that's flowing under the dam that's not really moving around, not being used. And so this is what we call the unstressed volume, and we're just using the stressed volume above it. And so when somebody gets septic or goes into septic shock and they start dilating, is that we lose a lot of that stressed volume. And so the response to losing that stressed volume is, let's fill it up, put more volume in there. Let's add some volume to add to that stress volume. And that's that volume that's going to go from your venous system back to your right heart to be able to give you preload. Another thing that you can do instead of adding all that volume would actually be to start vasopressors. And so by adding vasopressors, you're actually going to squeeze that reservoir, and you're going to take what's considered unstressed volume and then turn it into stress volume, because you're using the vasopressors to kind of squeeze down on there. And so that's another way you can add more stress volume without adding more volume overall. So mean systemic filling pressure. So mean systemic filling pressure, we found, is the pressure in the venules. So right after the capillaries, that's the pressure that creates a gradient between your venules and your right atrium that's going to push fluid or push blood back to your heart. So it is not MAP minus CVP to push back to your heart. It is only within the venous system. So it's post-capillary. You have your venules or your tiny veins, and they're going to have a resting pressure. And that pressure is higher than the right atrial pressure, and so it creates a pressure gradient. And that pressure is normally around 8 to 12. That's the normal mean systemic filling pressure for most people. And the concern with this is that if you start giving them a bunch of volume and you try to target a CVP of 8 to 12, then now you have a mean systemic filling pressure of 8 to 12. Now you have a CVP of 8 to 12, and you have no gradient. And while you may have fluid in your venous system, or you may have blood in there, is that you're not actually pushing it forward to create that stretch, create that preload in the heart to be able to have good squeeze and good cardiac output. So if we kind of combine these concepts, we have stress volume and unstressed volume, and then that creates a gradient, our mean systemic filling pressure minus our right atrial pressure. And so when somebody goes into septic shock and they dilate out their venous system, they have less stress volume, they drop their gradient, they have less blood flowing back to the right heart, and so they get hypotensive. And this way, because they have less preload, because they have less stretch, because they've lost their gradient of venous return. So if you give somebody a bunch of volume, looking at it from this concept, is that you may increase stress volume, but you also increase right atrial pressure. So while your mean systemic filling pressure may go up a little bit, your right atrial pressure goes up at the same rate. And so you don't actually change the gradient. So there's more volume in there, but it's still not creating that increase in gradient to allow venous return. Whereas if you look at it from doing vasopressors, is that when you start vasopressors, you'll actually squeeze all those venules to a higher pressure than it would squeeze from the right atrial pressure. So you would increase that gradient, which is going to push more fluid back to the heart, increase the amount of stress volume that's being used. That is more efficient than just keep using volume and volume and volume. And so if we look at these curves, which are like your Starling curves, is that if you look in yellow, which is the septic shock, is that if you keep giving, if you look at the different differences between mean systemic filling pressure and right atrial pressure, is you can make out a venous return curve. And so if you look at somebody that gets a whole bunch of fluid, is you actually will reduce venous return by using just fluid. Whereas if you add vasopressors, you're going to increase venous return, which is going to increase preload, which is going to increase cardiac output and oxygen delivery. So in order to shrink the reservoir, in order to optimize your mean systemic filling pressure, in order to increase your venous return, the answer is to give vasopressors, not think of vasopressors as a failure. And I think that's one of the biggest differences that we're seeing between the new guidelines. Whenever we talked about starting vasopressors early and getting to them if they're still hypotensive after volume resuscitation, is it used to be that people would say, leave a fed, leave them dead, or they would say things that would say like, let's try to just give one more liter of fluid to try to avoid vasopressors. And now we're seeing all the benefits of vasopressors and that we should be giving vasopressors in a timely manner. Again, by giving vasopressors, you're actually going to increase their SVR. You're going to make them have less of that high output failure. So there's so many benefits to being able to give vasopressors at an appropriate time. So let's put these concepts together. You have your inflammatory vasodilatation from cytokines. You have your capillary leak from cytokines. You have your stress versus your unstressed volume. You have your optimization of your mean systemic filling pressures in your CBP. These are all things that are kind of newer concepts in terms of how can we use these to be able to treat septic shock. And so let's look at what we can do, looking at what we can add to the big three being early fluids, early appropriate antibiotics, and source control. So what would be next after there? So earlier vasopressors, what we just talked about. Look at all these benefits of doing vasopressors early. Is there any literature that says there's benefits to doing vasopressors early? I like to say that vasopressors are not a failure. They should be added if you're still hypotensive after initial fluid resuscitation. And then that way you're able to get them on early instead of keep trying to do more and more fluid to try to avoid them. Whenever we're dealing with vasopressor choices, there's multiple options. People talk about using phenylephrine or dopamine occasionally, or Levophed or norepinephrine, epinephrine, vasopressin. All of these are being thrown out to say these are ones that should be able to be used. If we go all the way back to 2010, they actually looked at dopamine versus norepinephrine in just undifferentiated shock, which one was better. And what they found out was that they did somewhat similar, but dopamine had significantly more arrhythmogenic processes and it had a lot more side effects. And so now what we say is norepinephrine is the drug of choice for shock, undifferentiated shock. And so we usually have norepinephrine as our initial drug of choice for septic shock. That takes us to the Sensor trial that came out in 2019. The Sensor trial looked at early norepinephrine in septic shock, and what they found out was if they did early norepinephrine, they got better shock control at 6 hours. They had a better 28-day mortality, although it didn't reach statistical significance. They had a quicker time to reaching their MAP goal greater than 65. they had less cardiogenic pulmonary edema because they were given less fluids, and they actually had less arrhythmias because a lot of that, when the heart is empty and it's really hyperdynamic and it has no SVR to push against, is that it's going to be more prone to going into AFib or other rhythms. So vasopressors are going to, again, like we talked about, they're going to improve your stress versus unstressed volume, and they're going to optimize your mean systemic filling pressure versus your CVP. So that leaves us with early fluids, early appropriate antibiotics, source control, and then vasopressors. And again, first line being norepinephrine. And then we usually think of vasopressin as an adjunct as opposed to a second line, that it should be added with norepinephrine because it'll help reduce the dose of norepinephrine. And then second line being epinephrine. And then steroids. Where do steroids kind of fit into this? And specifically with hydrocortisone 50q6 being the most common. It's definitely, people talked about it saying if somebody got intubated and they used etomidate, that can cause adrenal insufficiency. And so they talked about putting on steroids during that time. But now we have some more literature kind of going forward. So if we look back in 2008 at the Corticus trial, they said whenever they gave stress dose steroids, it led to faster reversal of shock, but it didn't show a mortality benefit. So the people that were anti-steroid said, no mortality benefit, we're not going to give it. And then in 2018, there was the adrenal trial. Again, they used the hydrocortisone 50q6, faster reversal of shock, fewer ICU days, fewer ventilator days, less blood transfusions, but no mortality benefit. But also in 2018, there was the Approaches trial. And the Approaches trial used hydrocortisone plus fludrocortisone. And in patients with septic shock, they actually had a mortality benefit in patients that used hydrocortisone plus fludrocortisone. And so this was a big deal because it was really the first paper using stress dose steroids that showed that there was a mortality benefit whenever you gave it. So why does this work? This makes sense, right? Steroids are anti-inflammatory. It's going to help reduce that inflammatory vasodilatation. It's going to help reduce that inflammatory capillary leak. And so all that volume isn't going to leak out into the interstitium, and you're not going to be as dilated in terms of needing more fluid and having all that hypotension. So stress dose steroids, hydrocortisone plus fludrocortisone would be the next step. And then hypertonic fluids. So something to consider that says if we give hypertonic fluids, it'll stay more intravascular instead of leaking out because you have all this leaky fluid. 18 was the Bicar ICU trial, and they actually took hypertonic bicarb, which is 4.2% sodium bicarb, and they gave it in like 50 to 250 boluses. And they found that there was actually a mortality benefit in patients that were acidotic and had acute kidney injury. So hypertonic sodium bicarb decreased 28-day mortality if they had acute kidney injury and acidosis. When I do hypertonic bicarb, what I typically do is I do a 4.2% concentrations, just like the original Bicar ICU trial, but I'll take 5 amps of sodium bicarb and I'll mix it in 250 mLs of D5W. That will create a 500 ml bag of a 4.2% solution, and I'll just give it over 75 milliliters an hour for about 7 hours. What that's going to do is it's going to kind of want to keep all that fluid intravascular and not want to leak out. And it'll give you 7 hours of a really good intravascular volume while you're waiting for the steroids and the antibiotics and everything else to start working. And it's usually enough with just that one bag to be able to get you over that time period where they're in septic shock. Q4-hour labs, it was shown to cause some hypernatremia, although not very much, and then hypokalemia, which you would expect, and then hypocalcemia. So those would be the 3 electrolytes that you would want to look at while you're on it, but there's pretty minimal changes. So again, you can add considering hypertonic bicarb or even hyperoncotic albumin in this situation. So the 2018 also had the SWIPE trial, and they used 20% albumin in resuscitation. And so the idea with it being oncotic pressure or a protein is that it's going to stay in the intravascular space more, and it's also going to draw in a lot of that interstitial fluid. And so that way you're not having to give quite as much fluid. And in this one, what they found was there was no mortality benefit, but you use significantly less fluid overall by using 20% albumin as an adjunct to your fluid resuscitation. So these work by improving your mean systemic filling pressure to CVP because you're using less overall crystalloid, and then it help improve your stressed volume and your stress versus unstressed volume issues. Now, the next thing to look at is monitoring resuscitation. So you want to make sure that whenever you're resuscitating somebody, that you're resuscitating them appropriately, that you're giving them the appropriate treatment so that they respond, and then you don't want to over-resuscitate somebody. So if you give somebody fluid and they don't respond to it, you don't want to keep giving them fluid because that means that they're fluid non-responsive. So you don't want to keep doing that because it leads to side effects overall if you keep doing that. So whenever we're assessing for monitoring resuscitation, we would assess volume responsiveness, or we can measure lactics. Those are kind of the big two things that we look at. So monitoring resuscitation from assessing volume responsiveness is just knowing when to say when, or knowing when we can say, hey, this person may respond to a little bit more fluid. And this all has to do with the Starling curve. And this just saying we think they're on the lower part of the Starling curve. And if that we give them more volume, they'll go higher up on the curve. This will improve their cardiac output, improve their oxygen delivery. So one of the big things that people did back in the day was they did a passive leg raise. And so the idea is that if you put their feet up in the air, it would give them about 250 mLs of blood extra rushing back to the heart, and we would look for a response. So you would be looking for either a improvement in blood pressure or a reduction in heart rate, something that says they responded appropriately to the passive leg raise. Now, in the original study, as you can see in this picture, is they actually had beds where the foot of the bed was able to rise up, and so that made it a little bit better. The concern that does happen whenever people do a passive leg raise is that if you grab somebody's legs and throw them up in the air, is that can sometimes cause a lot of pain. And so you may see an improvement in blood pressure and think that they're volume responsive, when in fact they're just responding to the pain of having their legs grabbed and moved up into the air if they maybe are not used to those types of things with it. So something to be aware of between a passive leg raise where actually the foot of the bed goes up versus grabbing their legs and putting them up in the air. There's also IVC, and I like IVC. I think there's a lot of controversy around it. I think there's people that say, you have to be paralyzed. I've heard people say that. I've heard people say you have to have a 30% or a 50% variability for you to be considered to be volume responsive. I think in the extremes, it's very helpful. If your IVC is collapsed, then yes, you're going to be volume responsive. If your IVC is big and non-variable, then they're not going to be responsive. And I'm not going to get into the subtleties of other things you can do to help kind of better make your IVC exam a good opportunity to look at volume responsiveness. But I think looking at the extremes is very helpful. There's also looking at arterial pressure variation. So looking at your pulse pressure variation and how much your pulse changes on like your A line. And so the area under the curve of your A line is actually your stroke volume. So every time a patient takes a breath, is that it's changing how much blood return goes back to the heart, because it's putting a little bit of pressure on the IVC and the SVC. And so you're getting a little bit of less return to your heart. And so if you're having variations in your area under your curve of your A line, then that means you're having, every time you breathe, you're kind of collapsing your IVC and your SVC a little. If you have no variation, then that means you have so much pressure in your IVC and your SVC that even with breathing, it's not collapsing, which would say that you have so much pressure in there, so much volume in there, that you probably don't need more volume. And so a lot of what we look at is our pulse pressure variation to see if there's any variation with our breathing. We do the same thing with certain devices like a Visualeo device, where they actually look at this difference and it comes up with a number, and the magic number for them is 13%. So if you have more than 13% variation in your stroke volume in the area under your A line, then you would be deemed to be volume responsive. Whereas if it's less than 13%, they would say you're not volume responsive. So again, the whole idea of giving fluid is saying, I think you're low down on the Starling curve. I think you would benefit from fluid. If you don't think that they need fluid, or you don't think that they're low down on the Starling curve, then don't keep giving them fluid, because it's just going to lead to more side effects. Now, the big thing is monitoring lactates. This became a big thing to say, okay, well, their lactate's still 4, we need to give more fluid, or these types of things to say, we need it to be normal, we need it to be normal. They actually had the Andromeda shock trial that came out in 2019. And what they said was, we're going to look at when we decide to end our resuscitation is whenever our lactate normalizes, or whenever we have good cap refill. And so after they would do these volume resuscitations and these smaller amounts of fluid, is they would monitor the cap refill and say, do they have good cap refill? And if they were deemed to have good cap refill, then they stopped the fluid resuscitation. And in the other arm, they looked at saying, all right, we need to normalize that lactic. And they actually showed better outcomes with the ones where they looked at cap refill because they were giving significantly less fluid, because there's plenty of times where people had a lactic of 12 and now it's 5. So it's definitely getting better. You're improved. You're definitely on the better side of oxygen delivery, but you still give more and more fluid because the lactic's still high. And so they were just over resuscitating a lot of their patients. So let's look at if there's been more changes as we go forward. So let's look at if there's been any changes to the big 3. So one of the biggest one was early fluids. So 30 mLs per kg, strong recommendation, low quality of evidence back in 2016. Well, what we found out was there are a whole bunch of patients that are just not responsive to fluid. If we looked at this one, a third of all hypotensive patients were just not even responsive to fluid. And risk factors included heart failure, immunocompromised, elevated lactic greater than 4, that you could give them fluid and they showed no response to giving them. And so in those people, if there's no response to giving fluid, then you shouldn't continue to give fluid. Additionally, they looked at the amount of fluid. And what we found out was that if you had a high fluid balance after day 1, so day 2 until ICU discharge, you had an increased risk of mortality if you had severe sepsis and septic shock. And again, what this says is there's a lot of side effects of fluid, and the more fluid you give, the more side effects that are going to happen from it. So what I like to say is that sepsis is not a hypovolemic issue. You know, if somebody was normally sitting eating breakfast and then at 5 p.m. they're in the hospital and they have a UTI and they're in septic shock from a UTI, it's not like they became 5 liters dehydrated during that time point. What happened is that they vasodilated and they started third spacing. And so that patient is now fluid shifted. They have a dilated amount of vasculature and a lot of their fluid is now in their interstitium whenever it shouldn't be. So they're fluid shifted, not fluid down. So giving somebody 7, 8, 9, 10 liters of fluid just doesn't make sense because they're not 7, 8, 9, 10 liters of fluid down. It's just there's fluid where there shouldn't be fluid and it's not in the right places. So if you look back at the early goal-directed trial from 2001 with Manny Rivers, is that in 72 hours is that they averaged giving patient 13 liters of fluid. So if you looked at that over pounds, 13 liters is going to be almost like 28 pounds of fluid. And then if you look at the Process, Promise, and Arise trial and saying, well, how far have we come whenever in 2014, 2015, we came out with these trials, is that we've gotten a lot better, but we still average giving 7, 8, 9, 10 liters of fluid. So the US was the worst at 8 to 10 liters of fluid, whereas Europe and Australia and New Zealand did the best with about 7 or 8 liters of fluid. And then what about the type of fluid? So one of the things we've really discovered is that saline has a lot of side effects. That super high chloride, that's super normal, actually causes a lot of side effects. So saline, there's a paper, saline should not be the first choice for crystalloid resuscitation. Hyperchloremia and a moderate increase in serum chloride are associated with acute kidney injury and severe sepsis and septic shock. Balanced crystalloids should be the choice that should be given in somebody over normal saline. Among patients with sepsis, resuscitation with balanced crystalloid or albumin compared to other fluids seems to be associated with reduced mortality. If we look at this and we look at it overall and say at the papers, a lot of papers show a trend towards balanced crystalloid being preferred over normal saline, but there's a lot of them that don't show enough to say that there's a mortality benefit. Now, if you break them up between randomized controlled trials or observational trials, again, a lot of them show a trend towards balanced crystalloid being favored, but a lot of them cross the line to say that we can't prove a mortality benefit from a statistic standpoint. But if you look where they gave balanced crystalloid both in the emergency department and in the ICU, there actually is a very strong mortality benefit to say that balanced crystalloid is significantly better than normal saline. So by doing it throughout the entire stay, they get balanced crystalloid in the emergency department, they get balanced crystalloid in the ICU. That's where you're going to get the best benefit. And so in all these other studies, they would oftentimes get balanced crystalloid in either the emergency department or the ICU, but not together. And whenever they get them together, that's where you see that benefit, because all that chloride from that normal saline leads to acidosis, it leads to kidney injury, it leads to increased mortality. Now, people like to talk about cost, so I can tell you that at our institution, whenever we look at the cost from a hospital standpoint, is that it is minimally more expensive for ours, and there's other hospitals where it is not more expensive at all, but you're looking at a cost of $1.64 compared to $3. So $1.36 difference to say that you have improved mortality and improved outcomes. And then there was another paper that came out that looked at the effects of 5% albumin versus just saline alone in large volume resuscitation. And it actually showed that 5% albumin was associated with a reduced mortality because of the oncotic pressure. That oncotic pressure wants to stay intravascular considerably longer than any crystalloid. And so by staying intravascular, you're able to require less fluid, you're able to improve that preload, you're able to improve that cardiac output, and kind of reverse that shock a lot better than doing just crystalloid. So updating surviving sepsis. So now let's look at how all these things have affected what we've done for the 2021 guidelines. So in these guidelines, if we look at them, what we see is that they say we recommend against using Q-SOFA. And we talked about how Q-SOFA identifies the really sick people, but it does miss some people that are kind of trending in that direction. So they actually recommend either SIRS, NEWS, or MUSE. And I would say NEWS or MUSE are probably better than SIRS. And so a lot of hospitals are kind of implementing them within their electronic medical records to help from an identification. So that's a new recommendation after all this literature kind of came out with all of that. Additionally, if we looked at some other things with it and we look at for patients with hypoperfusion, we suggest 30 mLs per kg of crystalloid. Or whenever we look at the first picture, we can see that it says we recommend the treatment and resuscitation begin immediately. Whenever we talk about the 30 mLs per kg, they have downgraded it from strong low quality of evidence to weak low quality of evidence. So that whole 30 mLs per kg craze that kind of happened after the 2016 recommendations, now we're starting to see all the complications and side effects that happen from that. And they're starting to say, look, this is maybe not everything that we thought it was going to be. They wanted to tone it down and say, we now do not recommend as strongly for that 30 mLs per kg. It is now a weak, low quality of evidence. We talked about using dynamic measures, using that the passive leg raise or the stroke volume variation or bedside ultrasound or something that's going to say, does this person need more volume resuscitation? And then you look at them, they say like guiding resuscitation to decrease serum lactic. So what we found out from the Andromeda shock trial is that, you could also just use capillary refill. And so that's what the new recommendations show here is that they say we suggest using cap refill to guide resuscitation. So that's a new recommendation from 2016. But it is weak, low quality of evidence, but it comes from that Andromeda shock trial. Now, for patients with septic shock, and they look at antimicrobials, what we've done is we've separated out septic shock from sepsis, and I think this is really important. So if somebody's in septic shock, as in they have signs of organ failure, then they want antibiotics within the first hour, just like we saw in the 2018 golden hour. And they recommend you try to get it as fast as possible. And that usually means broad spectrum antibiotics. Now, in patients that were in sepsis without shock, they've actually changed to say that they recommend antimicrobials within 3 hours. And they're saying, we want to give you the opportunity to kind of do a deeper dive, figure out, is it pneumonia? Is it blocked kidney stone? Is it a UTI? Something where you can kind of get a better idea what the source is so you can get a more specific antibiotic, and so you're not just doing broad spectrum antibiotics on everybody. And so this is new to say that they were giving them up to 3 hours if they're septic without shock. And again, they talked about crystalloids as the first line of therapy. That's still what the recommendation is. But it says we suggest using balanced crystalloid instead of normal saline. This is a new recommendation. Now, it's weak, low quality of evidence. But if you remember, so is the 30 mLs per kg. So it has just the same amount of data and recommendation with 30 mLs per kg to say balanced crystalloid over normal saline. And so this is a new recommendation. It shows that mortality benefit. It's saying we now recommend balanced crystalloid in our guidelines. And then additionally, what it says is they actually recommend using albumin if you're going to be doing a large volume resuscitation. And again, it comes from that SWIPE trial. It comes from that 5% albumin trial that showed that there is a benefit to using albumin. And so the benefits of oncotic pressure is that proteins want to stay inside your intravascular space a whole lot longer than just crystalloids. And so you get that benefit. So it's not recommending them first line, but it's saying if you're going to be using large volume resuscitation, they do recommend adding albumin to that to be able to help as an adjunct. Now, norepinephrine is first line. We talked about that from the SOAP-2 trial that looked at norepi over dopamine. Then they suggest adding vasopressin and then adding epinephrine as their second line. Those are all still the same recommendations that we have. Now, they do suggest invasive monitoring for your arterial blood pressure for everybody, just because it does lead to better indications of what their blood pressure are. And then so it's a lot more reliable, especially in somebody in shock. And then the big thing is that they recommend starting vasopressors peripherally. And I think this is really big because I was at a time that got trained. It says you can only give vasopressors through a central line. And so if you were really busy or there was a lot going on or there were things that you would always want to just kind of lean towards saying, just give them 1 more liter of fluid. I don't really want to put a central line in this patient. So now what they're saying is not only is it safe to give vasopressors peripherally, but it's actually a recommendation to give them peripherally so that people are more likely to go ahead and start vasopressors early, and you can see those benefits of early vasopressors. Now, one thing that I think is new and really interesting is that they actually put in a comment about large volume versus low volume resuscitation. And their comment was, we can't make a recommendation right now. But I think this is a huge statement to say is that it's now in the conversation, whereas like it was never in the conversation before, where we can say like, look, I think we're over resuscitating our patients. I think we're giving them way too much volume. Now what they're saying is we're aware that there's different ways of giving volume. There's a fluid restrictive and fluid liberal strategy. And we're not going to make a recommendation right now. But I think with the new guidelines is that they'll probably start leaning towards making a recommendation. And my thoughts are towards a fluid restrictive standpoint to try to avoid over resuscitation. And then we suggest using IV corticosteroids. That is an upgrade from weak, low quality of evidence to weak, moderate quality of evidence. And then they also recommend using sodium bicarb. So again, that is specific to patients that are acidotic, pH less than 7.2, and have an acute kidney injury. So in that situation, they actually recommend bicarb therapy, and that comes from the Bicar ICU trial. So keep that in mind in any one of your patients, because that's going to be a high patient population that says this patient is acidotic and they have signs of acute kidney injury, is that you can give them bicarb therapy. Now, they don't specifically say hypertonic bicarb, but I think there's a lot of benefit to using hypertonic bicarb. So if we look at treating septic shock today, early restrictive fluids, early appropriate antibiotics, source control, vasopressors, stress dose steroids, hypertonic fluids, frequent volume responsiveness reassessment, and then de-resuscitate them, get that fluid back off of them whenever they're out of shock. And again, if you have a leaky 6-liter bucket, the answer shouldn't be to just start pouring more and more fluid in there as fast as you can to try to fill up a leaking bucket. The answer is try to patch the bucket or try to shrink that bucket back down. And so by giving some fluid that'll help fill up the bucket from the leakiness, but fix the leak, give steroids. That's going to help that leakiness and kind of that anti-inflammatory response. Shrink that bucket back down to 4 liters with vasopressors. And then you can also think about it as thickening the fluid by giving hypertonic fluid like hypertonic bicarb, or giving that hyperoncotic albumin, the 25% albumin. So again, let's go over the objectives. We talked about the history of septic shock resuscitation. We talked about the 2018 guidelines, the new Sepsis 3 update. We talked about how the pathophysiology of sepsis occurs, and then how all of the pathophysiology and then data that's come out since 2018, how they've helped mold and shape the 2021 surviving sepsis guidelines. Thank you very much.